Assalamu alaikum. Bismillahir Rahmanir Rahim. Quote for the day is: The secret of change is to focus all your energy not on fighting the old, but on building the new. The topic for today's presentation is Zika virus. I am Dr. Ayesha Amin, FCP's PGR Community Medicine at Institute of Public Health, and I'll be presenting this under the kind supervision of Professor Dr. Saira Afzal. The learning outline for today's presentation is Introduction, Epidemiology, the modes of transmission and clinical manifestations of Zika virus, treatment of Zika virus, levels of prevention, recent advances in Zika virus, and the multiple choice questions. Learning objectives. At the end of the presentation, the participants will be able to describe the epidemiology of Zika virus, the sign and symptoms, diagnosis and treatment of Zika virus, prevention for Zika virus, and to be able to answer the MCQs. Starting with the case scenario, a 33-year-old woman who visited Brazil with her husband in November last year. She was in her 11th week of pregnancy and remembered being bitten by mosquitoes. The day after her arrival home in the US, she developed ocular pain, myalgia, mild fever, which lasted 5 days. She broke out in rash on the second day. Meanwhile, her husband also developed symptoms. A month later, she tested negative for IgM antibodies to dengue and was positive for both IgG and IgM antibodies to Zika virus. Ultrasonography at 1, 4, and 6 weeks after the infection showed no intracranial calcification or microcephaly in the fetus. The Zika virus was detected by reverse transcriptase PCR. At 19th week of gestation, the ultrasound showed abnormal intracranial anatomy of the fetus. The fetal MRI performed at 20th week of gestation showed various changes in fetal brain with diffuse atrophy of cerebral mantle. The patient chose to terminate the pregnancy at 21st week of gestation. Starting with the introduction, Zika virus is a mosquito-borne virus which is very similar to the dengue and yellow fever. It is transmitted primarily by the Aedes mosquito, which includes Aedes aegypti and Aedes albopictus. As we all know, they bite mostly during the day. As far as the structure of the Zika virus is concerned, it belongs to the flavivirus family. It is enveloped, spherical, and single-stranded RNA virus. History of Zika virus. The Zika virus was first identified in Uganda in rhesus monkey in 1947. In the year of 1950, the evidence of infection and disease in human in other African countries were found. During the 1960s and 1980s, there were sporadic human infections were detected across the Africa and Asia. In 2007, the outbreaks of Zika virus disease have been recorded in Africa, America, Asia, and Pacific. There was the first large outbreak in humans on the Pacific island of Yap, the federated state of Micronesia, which reported 49 confirmed cases and 59 probable cases with no deaths. During the year of 2013 and 14, the virus causes outbreak in 4 other groups of Pacific Island, that is French Polynesia, Easter Island, the Cook Island, and the New Caledonia. During 2015, there was a larger epidemic in Brazil in which an association was found between the Zika virus infection and the microcephaly in the developing fetus. There were 440,000 to 1,300,000 cases have been reported. On February 1st, 2016, the WHO declares that the recent infections of Zika virus and its association with microcephaly and other neurological disorder, it constitutes a public health emergency of international concern. On November 18, 2016, the WHO Emergency Committee felt that the Zika virus and its consequences remain a significant public health challenge which require intense action, but it is no longer a public health emergency of international concern. The epidemiology of Zika virus. The cases of Zika virus disease globally declined from 2017 onwards. As of December 2021, a total of 89 countries and territories have had documented evidence of mosquito-borne transmission of Zika virus distributed across 5 of the 6 WHO regions except the EMRO region. This diagram shows the countries and territories with current or previous Zika virus infection. As we can see the dark blue highlighted area shows the countries and territories with current or previous Zika virus infection, while the light blue color shows the countries and territories with established competent vector, but there are no case of Zika virus infection. This is the list of countries which have the previous Zika virus transmission. They have all the five regions of WHO except the EMRO region. Zika virus in Pakistan. There is no confirmed case of Zika virus in Pakistan. As we can see in the list, in the EMRO region, the Pakistan, where the Pakistan lies, there is no case of Zika virus. Coming to the epidemiological determinants of the Zika virus, the agent of Zika virus infection is Zika virus. The host is human. There are certain environmental factors which are socioeconomic factors, poor sanitation. There is if there is lack of vector control and the climate change. And vector is Aedes aegypti mosquito, which includes Aedes albopictus and Aedes aegypti. Modes of transmission. There are certain modes of transmission of Zika virus, that is from mosquito to human, vertical transmission, sexual transmission, and blood-borne transmission. The first mode of transmission is from mosquito to human, that is transmitted primarily by Aedes mosquito, which includes Aedes aegypti and Aedes albopictus. In tropical and subtropical regions, the mosquito, they typically breed in domestic water holding containers. They bite mostly during the day, and they feed both indoor and outdoor near dwellings. Vertical transmission. The Zika virus, it can be transmitted from a person who is pregnant to their fetus during pregnancy, that is congenital transmission, or around the time of birth, that is perinatal transmission. The Zika virus, it has been found in the breast milk. Zika virus infection have been identified in breastfeeding babies, but spreading Zika virus through breast milk has not been confirmed, because current evidence suggests that the benefits of breastfeeding outweighs the risk of Zika virus spreading through breast milk. Sexual transmission. The Zika virus, it can be sexually transmitted from a person who is infected, even if asymptomatic, to their sex partner. Zika virus, it persists longer in semen than other body fluids. For blood-borne transmission, there have been no confirmed cases of Zika virus being spread by the blood transfusion in United States. However, cases of Zika virus transmission through platelet transfusion have been documented in Brazil. The incubation period of Zika virus disease is from 3 to 14 days. Clinical manifestations of Zika virus. Approximately 80% of the people who are infected with Zika virus are asymptomatic. The clinical illness is actually mild, and the symptoms may last for several days to a week. They are characterized by acute onset of fever. There is maculopapular rash, arthralgia, myalgia, non-purulent conjunctivitis, and headache. Diagnosis. There are certain tests performed for the diagnosis of Zika virus. The first test is nucleic acid amplification test, or NAT, which include RT-PCR, that is reverse transcriptase polymerase chain reaction, which is used to detect the viral genomic material. It can provide the confirmed evidence of infection. Despite the specificity of molecular testing, false positive NAT results have been reported. Because of the short period and low level of Zika virus RNA in the serum, a negative NAT does not exclude Zika infection. For this reason, another test, that is Zika virus immunoglobulin IgM antibodies testing, is recommended in certain situations. IgM generally is detectable during the first week after onset of the system, and it persists month to years. IgM testing is complicated by the cross-reactive antibodies to other flavivirus, which is a drawback for the testing of IgM antibodies. The third test is the plaque reduction neutralization test, that is PRNT, which measures virus-specific neutralizing antibody titers. It is considered as gold standard serological test for arboviral diagnosis. But the PRNT is costly. It requires highly trained staff, and it generates results that are complex to interpret. So they should only be performed in laboratories with suitable containment facilities. PNRT has an advantage that it may resolve the false positive IgM antibody results that caused by the non-specific reactivity, and it helped to identify the infecting virus. Coming to the treatment of Zika virus, there is no specific treatment available for the Zika virus. The patient are asked to have bed rest, drink plenty of fluids, and treat symptoms with antipyretic or analgesic, that is acetaminophen. Non-steroidal anti-inflammatory drugs, they should be avoided until dengue virus infections are ruled out because of the risk of bleeding. If the symptoms worsens, the patient should seek medical care and advice. Complications, the case fatality ratio is less than 1%. Some people who require hospitalization, they may have certain complications which include the Guillain-Barré syndrome, encephalopathy, meningoencephalitis, myelitis, uveitis, severe thrombocytopenia, and neuropathy. Uh, so coming to the Zika virus related GBS, some evidence shows that the mosquito-borne Zika infection may trigger Guillain-Barré syndrome. GBS is a rare condition in which the immune system attacks the peripheral nervous system. For some, GBS can be quite serious, which cause muscle weakness, sensory problems, pain, and sometimes paralysis. A possible explanation for this association is the molecular mimicry, that is, the immune response that is directed towards an infectious agent is also directed towards the peripheral nerve and endings, that is, gangliosides. Zika virus in pregnancy. Zika virus can affect women who are pregnant. Zika virus during pregnancy have evidence of Zika-related complications in the fetus. Congenital malformation occur following both symptomatic and asymptomatic infections. Zika infection in pregnancy can also cause fetal loss, stillbirth, and preterm birth. Zika virus infection, they does not affect the future pregnancies. Zika virus NAT testing, that is nucleic acid amplification test, should be performed as a part of routine obstetric care to asymptomatic pregnant women with ongoing possible Zika virus exposure, that is, if they are residing in or are frequently traveling to an area with the risk of Zika virus transmission. This picture describes the chances of having birth defect in the fetus, and they are highest if the mother gets the Zika infection during the first trimester, that is 8%. In second trimester, the chances are about 6%, and in third trimester, they are about 3.8%. Coming to the congenital Zika syndrome, Zika virus can be passed from pregnant females to their fetus. The risk of congenital malformations following infection in pregnancy remains unknown. An estimated 5 to 15% of infants born to women infected with the Zika virus during pregnancy had evidence of Zika-related complications. The Zika virus, it does not cause birth defect for every baby who is exposed to the virus before birth. Infection with Zika virus during pregnancy simply increase the chances of these problems. So Zika virus infection during pregnancy cause certain birth defects in the baby, which includes microcephaly, problems with brain development, feeding problems such as difficulty in swallowing, hearing loss and vision problem, seizures, decreased joint movement, that is contractures, and stiff muscles, which makes it difficult to move. This picture again shows the congenital Zika virus syndrome and and certain features of congenital Zika virus that has microcephaly, again difficulty in swallowing, contractures, seizures. So not all the babies who are born with congenital Zika syndrome will have all of these conditions. Some infants who do not have microcephaly at birth may develop it later. In addition, some babies, they might look healthy at birth, but they can develop long-term health problem as they grow. Congenital Zika virus recommended screening. Zika virus testing is recommended for infants with clinical findings who are consistent with the congenital Zika syndrome and possible maternal Zika virus exposure during pregnancy, regardless of the maternal testing results. Because of the level of Zika virus RNA and IgM antibodies, they decline over time. Laboratory testing of infants should be performed as early as possible, preferably within the first few days after birth. Testing CSF for Zika virus RNA and Zika virus IgM antibodies should be considered, especially if the serum and urine testing are negative and other etiology have not been identified. Zika virus and torches infection. As we all know, torches infections are a group of infectious diseases that affect a developing or a newborn baby. If you get a torch infection, you can pass it to your baby during pregnancy, during delivery, or even after birth. So, the O in the torches, it includes others which have infections like syphilis, varicella zoster, parvovirus, B19, and Zika virus. Coming to the prevention of the Zika virus, there are three levels of prevention, that is primary, secondary, and tertiary. In the primary prevention, we all know there is a health promotion and specific protection. In health promotion, we can go for the school education, educate the school staff, teachers, and volunteers on Zika and other vector-borne diseases. School can contact the Ministry of Education for the guidelines on mosquito control. Counseling, offering antenatal care and family planning counseling to help people make informed decisions about sexual and reproductive health. Avoid mosquito bites. For this, you can use an EPA registered insect repellent containing DEET, picardin, paramethane oil. Wear long sleeve shirts and pants. Sleep in a screened in or air conditioned room. Use mosquito netting and get rid of standing water. Limit travel. Avoid traveling to the places who are known for the Zika outbreak. Also, the travelers who are returning from Zika affected areas, they should not be allowed to donate blood until the risk of infection has passed, which is 28 days after returning from a Zika infected area. Prevent sexual transmission. Practice safe sex, that is, condoms can reduce a person's chance of getting Zika from sex. Condoms include both male and female condoms. The male should use condoms or they should not have sex for at least 3 months, and female should use condoms or they should not have sex for at least 2 months. Wait before trying to conceive. If you were exposed to Zika, wait at least 8 weeks after the last possible exposure or after symptoms start before you try to conceive. Vaccination. No vaccine is yet available for the prevention or treatment of the Zika virus infection. Development of the Zika vaccine, it remains an active area of the research. Secondary prevention, which includes the early detection and screening, early detection and timely management of the suspected Zika patient. Then carefully monitor people who are pregnant with laboratory evidence of Zika virus infection. Closely manage these patients during pregnancy and carefully evaluate the live-born infant for clinical features of the congenital Zika virus. Tertiary prevention. It includes the rehabilitation services which can be provided to the patients with Zika virus associated GBS, which includes physiotherapy, speech therapy, exercise, and recreational therapies. WHO response. WHO supports countries to conduct surveillance and control of arbovirus through the implementation of the Global Arbovirus Initiative, which is aligned with and expands upon recommendations laid out in the Zika Strategic Response Plan. The WHO responds to Zika in the following ways. It supports the countries in confirmation of the outbreaks through its collaborating network of laboratories. It provides technical support and guidance to the countries for the effective management of the mosquito-borne diseases. It reviews the development of new tools, including insecticide products and application technologies. It formulates evidence-based strategies, policies, and outbreak management plan. It provides technical support and guidance to countries for the effective management of the cases and outbreaks. It also supports countries to improve their reporting system. WHO providing training or clinical management, diagnosis, and vector control at the regional level with some of its collaborating centers. It is also publishing guidelines and handbooks on epidemiological surveillance, laboratory, clinical case management, and vector control for Zika virus. Recent advances in the Zika virus. The article is Current Advances in Zika Vaccine Development. It was published in PubMed. It was published on October 22, and the article states that there is no specific vaccine or drugs have been approved for Zika virus. However, some are undergoing clinical trial, which includes the vaccine like particles, inactivated virus, live attenuated virus, peptide and protein based vaccine. passive immunization by using monoclonal antibodies and vaccines that target vector drive antigens. The vaccines have been shown to increase the specific humoral and cellular immune response and reduce viremia and RNA titers, both in vitro and in vivo. The study demonstrated that the Zika virus NS1 protein is highly immunogenic and it can elicit protective antibodies, underscoring its potential for an effective Zika virus vaccine, suggesting that the antibody response against the Zika virus NS1 protein is long lasting and is functionally active. The second article, which was published in the Asian Pacific Journal of the Tropical Medicine, it states that the advances in Zika virus vaccine and therapeutics. Currently, although many vaccine candidates for Zika virus are at different stage of development, none of them have received Food and Drug Authority approval for use up to now. The issue of side effect associated with these drugs is vulnerable to newborn and pregnant women, and it's a major obstacle in the therapeutic pathway. There are certain drugs which are being used in the trial phase that are polymerase inhibitors, that is 7-DMA, pyrimidine synthesis inhibitor, briquinar, daptomycin, sertraline, pan-caspase inhibitor, sofosbuvir, ribavirin monophosphate, S-adenosyl L-homocysteine. They all have been previously being tested against HIV, Ebola, and VSV. Galidesivir, an adenosine nucleoside analog, is also being tested. Most of these drugs candidates have already been checked for their established efficacy against other viral infections such as yellow fever, dengue, Ebola, influenza, and they are now being in the trial phase for the treatment in Zika virus infection. Time for the MCQs. The first MCQ is a 26-year-old married female which recently returned from a trip, has complained of fever, muscle aches, and headache. She went to the physician and he was suspecting Zika virus infection in the patient. How long one should wait after exposure to Zika before trying to conceive? A. Wait at least 3 months after exposure to Zika before trying to conceive. Wait at least 8 weeks after exposure. C. Wait at least 2 months after exposure after symptoms start before trying to conceive. D. Wait at least 6 weeks after symptoms start before trying to conceive. The answer is B. Wait at least 8 weeks after exposure. The second MCQ is the incubation period of Zika virus. It varies between 2 to 10 days, B 5 to 15 days, C 3 to 14 days, D 4 to 12 days.
A.
The answer is C 3 to 14 days. 3. What is the primary mode of transmission of Zika virus? That is A. Mosquito bite, B. Sexual contact, C. Person to person contact, and D. Airborne.
A.
Yes, A is the right answer. That is mosquito bite. Number 4. What percentage of infants born to women infected with Zika virus during pregnancy may have evidence of Zika related complications? A. 30%, B. 25%, C. 5 to 15%, D. 20%. The answer is
B.
5 to 15%. 5. The Zika virus is primarily transmitted by mosquitoes, but it can also be transmitted via sexual contact. What is the recommended period for men with Zika virus to avoid unprotected sex? A. 1 week, B. 3 weeks, C. 3 months, D. 6 months.
B.
No, the answer is C. 3 months. 6. A 28-year-old woman present to the clinic with fever, rash, and joint pain after returning from a trip to Brazil. She reports that her symptoms started about 5 days ago. The physician suspects Zika virus infection and orders laboratory test. Initial results shows mild elevation of the liver enzyme, but no definite diagnosis was made. Which diagnostic test should be prioritized for confirming Zika infection in this patient? Number A, option A, IgM antibody testing. B, enzyme-linked immunosorbent assay. C, plaque reduction neutralization test. D, nucleic acid amplification test.
Option C.
The correct answer is option D, that is nucleic acid amplification test. MCQ number 7. Which of the following is a critical factor that can influence the geographical spread of Zika virus? A, urbanization and population density. B, air travel. C, seasonal changes in mosquito population. D, all of the above. The answer is D. MCQ number 8. Zika virus is known to primarily affect which of the following population during an outbreak? A, children under 5 years of age. B, elderly individuals with chronic diseases. C, pregnant women. D, immunocompromised patients.
C.
C is the right answer, pregnant women. MCQ number 9. Which of the following are true regarding the management and treatment of Zika virus infection? A, there is specific antiviral treatment available for the Zika virus infection. B, treatment for Zika virus infection is symptomatic, focusing on relieving fever, rash, and joint pain. C, pregnant women diagnosed with Zika virus should not consider termination of pregnancy. D, Zika virus infection can be prevented through the use of antiviral drugs if administered immediately after exposure.
B.
Yes, B is the right answer. The last MCQ is which country reported a major Zika virus outbreak in 2015? Number A, United States. B, Brazil. C, Canada. D, India. The answer is Brazil, B. This is the key for the MCQs. These are my references. This is our YouTube channel where all the presentations are uploaded. Thank you for listening.